Welcome to NEJM In Studio, your destination for discussions with experts about thought-provoking issues in medicine and health. My name is Dr. Harleen Marwah, NEJM Editorial Fellow. For years, race-based adjustments in clinical algorithms has been a widely debated topic. Although race is a social political construct used to categorize people, it has also historically been used and is currently being used in medical teaching and clinical decision-making. Given the complexity of this issue, researchers have been working to disentangle the social consequences of racial health disparities in genetic ancestry to identify root causes in order to implement appropriate interventions. Today, we're sitting down with Dr. David Jones, the Ackerman Professor of the Culture of Medicine at Harvard University. Trained in psychiatry and the history of science, he has focused his research on the causes and meaning of health inequities and the history of decision-making in cardiac therapeutics. Dr. Jones also served as the guest editor for the NEJM series, Recognizing Historical Injustices in Medicine in the Journal. With Wenjil Xue, he recently co-authored Debating Race and the Diagnosis of Anemia, How Medicine Moved Away from Race-Based Standards, the article that we'll be discussing today. Dr. Jones, thank you for being here.
Thank you.
So today we're excited to talk about this article that you've written, but I wanted to start by taking it back to an article that you co-authored in 2020. In Medicine and Society article in the journal, you and your colleagues described race adjustments in clinical algorithms as subtle insertions of race into medicine that often, quote, guide decisions in ways that may direct more attention or resources to white patients than to members of racial and ethnic minorities. Since that time, many specialty societies and bodies of experts have been re-examining race-adjusted algorithms in their fields and revisiting them to make things more equitable. So what led you and your co-author to examine anemia diagnosis in particular?
Much of the attention over the past 5 years has focused on a small number of tools, the tests to diagnose kidney function and pulmonary function especially. But those are just 2 out of our 2020 article. We wrote about 13, and that list of 13 was selected from a longer list of 25 or 30 or so that we found on a relatively quick search. If you were to look most expansively across medicine, how many tools used race as a variable? I don't actually have an answer to that question. But one of the ones I had never thought of looking at was, in a way, one of the most common and basic ones of all, which is what is the threshold for hematocrit or hemoglobin levels to diagnose anemia. It just hadn't crossed my mind. I can't give it a good explanation of why. But over the past few years, I've participated in a panel that's part of the genetics class at Harvard Medical School, where they have a series of social scientists come in to talk about how we think about race in contrast to how geneticists have thought about race. And after one of those lectures, one of the first-year students, Wenjil Xue, came up to me afterwards and said, well, what about anemia? And I said, that's an excellent question. Do you need a research project? And so she signed on and really did most of the basic sleuthing for this, looking into this question. And one of the things that was really helpful is after that 2020 article, I've started working with colleagues at other institutions and other universities. And one of the groups that has been a big force behind digging into this has been the Doris Duke Foundation. And so through colleagues at Doris Duke, I had connections to some of the various medical specialties. And so one question we had was, well, if this is a question of anemia, what have the hematologists thought? And so we reached out to the American Society of Hematology, and they said, that's a very good question. And my hope had been that they would open their archives to us and we would be able to dig around. But they did their own audit internally. And so we waited a few months and they came back with an answer and said, in fact, as far as that society could tell, they had never implemented a race-based threshold for anemia, which was really interesting because very many medical societies did have race-based tools. Oncologists did, cardiologists did, gastroenterologists did, nephrologists did. And so again, this question, well, why didn't hematology do this? Since if we're going to ask American doctors, what's the classic race-based disease, they're going to say sickle cell disease, which in the U.S. has always been seen as a racialized disease. So it was a really interesting question. Why was this very common question, diagnosis of anemia, not examined for a race-based threshold in a country where diseases in hematology often have been seen as racial diseases. So it's a really interesting question. So we set out to see what we could find out.
Yeah. No, I love that. I think, one of the joys of working with learners is that they ask such insightful questions. And so exciting to hear that the initial question from this came from a medical student who had this interest. As I read your article, there were a couple of things that really stood out to me. I think one is something you touched on, the discrepancy between how different medical societies handled determining these thresholds. And then the other thing was learning about how this debate began with some of its roots in addressing poverty and malnutrition. Can you tell us more about that and kind of the origins that were rooted in those things?
Yeah, so the specific backstory there was in the 1960s and 1970s as part of the war on poverty that came out of President Johnson's administration. There was a lot of concern about poverty and malnutrition in the United States. So the federal government funded a series of studies that came to be known as the NEJM studies that really were comprehensive demographic surveys. They looked at a large sample of the population and measured all sorts of variables, where they lived, demographic variables, were they rich or poor, what was their race or ethnicity, what was their hemoglobin level, was one of the laboratory measures they looked at. And as they started to do analyses of this data set in the 1970s, they realized that if you divided the people they had tested based on the basic race categories, whites and blacks in America, the average hemoglobin level across the black people in the sample was lower than the white people. And this was true for both children and adults. And this wasn't a sample of sick people in hospitals. This was a sample of presumably healthy people living out and about in the community.
Mm-hmm.
And so they saw that race difference. And this is a finding that has been reported in many, many other studies. It wasn't unique to this one study. And the question is, what does that mean?
Mm-hmm.
And it could have meant many things. Again, the origins of the study were concerns about poverty and malnutrition. So one explanation, which was totally plausible in the United States in the 1960s, was that African Americans on average were poorer than white Americans. They would be more likely to be living in what we would now call food deserts than white Americans. So maybe as a group, there were higher rates of iron deficiency and then iron deficiency anemia that were driving these lower hemoglobin levels. And that was a totally reasonable speculation. Now, if that was true, doctors wouldn't want to set their diagnostic threshold lower because what you would be doing is telling this entire community of people who are malnourished that that was actually normal and medicine wasn't going to do anything about it. And social policy wasn't going to do anything about that. And that would be sort of a toxic, perverse thing to do. A different explanation would be that, well, maybe these two groups, white Americans and black Americans, are different races in the biological meaning of race that was common at the time. And maybe there was something genetically different about these two groups, such that the difference in hemoglobin level reflected a fundamental underlying difference between these two groups of people. And so therefore that was normal. And so if you were to use the same threshold for diagnosis of anemia, you would be overdiagnosing black people with anemia. And that would be bad because if you diagnose people with anemia, you want to put them on iron.
Right.
Anyone who's taken iron supplementation knows it has some side effects, especially constipation is the one people complain about.
Yeah.
And so do you really want to consign the entire population of African Americans in this country to a life of iron supplementation and constipation? And so it's really important to understand what was the cause of that observed difference before people figured out how to respond to it.
Yeah, definitely. No, I think that you raise so many important points there. And I think one of the things that really struck me was we think about these race-based thresholds in terms of clinical medicine, but then we also take a step back and realize that whatever thresholds that we're using in medicine have these broader societal impacts for social policy, like you said. And it's important to consider some of those confounding factors or social determinants of health and how those really play in. One of the things that I think about a lot, especially as a pediatrician, and we're doing well child checks where we're checking hemoglobin levels and looking for anemia in little ones, is the impact that these thresholds could have had on the special supplemental food program for women, infants, and children, otherwise known as WIC. I was wondering if you could just talk a little bit more about those sorts of broader implications that this threshold had.
Yeah, so even though doctors often see what we do as confined to the domain of health, there's often spillover. Medical assessments can be important for disability determinations, and medical assessments of this case in anemia, if that's evidence of nutritional deficiency, then become significant for how certain kinds of benefits, as you said, the WIC program would get allocated. And so the question here was, do you have one threshold for anemia for all women or for all children, such that if you're below, you get special benefits from WIC? Or even would you qualify for WIC altogether? And since the African American average hemoglobin level was lower, those people were more likely to qualify if you were using a single threshold than white patients would be. And you can argue about whether that's good or bad. Again, part of that depends on what's the cause of the population difference in hemoglobin levels. But given that that was true, that there was this difference, if instead what you said was, okay, we're going to move the threshold for Black patients lower, so now your hemoglobin level has to be a point lower than it used to be to qualify, what this would mean is that a lot of Black women and children who had qualified for WIC would no longer qualify for WIC. And in a country that was still grappling with the civil rights movement and was still very aware of the fact that there was a lot of discrimination against African Americans and a lot of structural poverty that affected these communities, for doctors to make a shift in their diagnostic thresholds, which would have the effect of taking a lot of poor Black women and children off of WIC, was something I think a lot of doctors are really uncomfortable with the prospect of doing. And if you were going to do something like that, you'd want to be really confident that you were doing it for the best scientific evidence-based reasons. And so lots of groups got together to try to argue this out and see if they could have good data and could come up with good explanations that would justify a policy that would have that social and political implication.
Yeah, I think it brings up so many good and important points. One of the things that I often think about is how you would actually put some of these things into practice. Like you're saying, if you had two separate thresholds, then, who's actually, is it self-reported race? Is the provider assigning the race to the patient? You can see there's so many places for pitfalls actually in implementing this. And then unfortunately, it's often some of the most vulnerable patients who fall through the cracks. I want to go back to something that you mentioned earlier, which was some of the discrepancies that we saw from specialty societies or groups like the CDC or the Institute of Medicine at the time, and their different takes on this. Can you talk a little bit about how different national organizations responded to this and why there were differences among them?
So the Centers for Disease Control was one of the first groups to dive into this in the 80s into the early 1990s, in part because they were concerned about chronic disease and health and nutrition. And so they were very interested in the data that was coming out of NHANES. And if their goal is to try to monitor levels of nutrition and anemia, it was important for the CDC to have clear ideas about these thresholds. And so they convened a working group that met in the early 1990s to look at the NHANES data and decide whether or not they should do a race-specific threshold. And we spoke with some of the people who were involved in that, and it was hard to get a totally clear story 30 years after the fact about what happened. And the best that we could conclude was no consensus was reached. I'm not sure if they made an active decision not to do it, but they didn't make a strong decision to implement a race-specific standard. So the baseline practice, no race-specific standard, persisted. So the CDC looked at the question, didn't make a decision to change anything, so they kept the old practice going. My sense is that there was disagreement about that. So a few years later, this is now in the mid-1990s, the Centers for Disease Control asks the Institute of Medicine, now the National Academy of Medicine, to look into this question again. By this point, there'd been more data coming. The NHANES project was an ongoing survey, and so there keeps being new data coming into this to inform these discussions. And so the Institute of Medicine does recommend implementing race-specific thresholds for anemia diagnosis. And for reasons we couldn't totally figure out, the CDC decides not to implement that. So the CDC gets the recommendation from IOM and seemingly sets it aside. Meanwhile, there are many different medical professional societies who are interested in these questions. As I said at the beginning, you would have expected the American Society of Hematology to be involved, but as far as they could tell, they never took this up as a serious consideration. The American Academy of Pediatrics was very interested. They're very concerned about the health of children, especially child malnutrition. And so they're always paying close attention to these things. They established a working group, and in 1998, they decided to go ahead and recommend race-specific thresholds for anemia diagnosis in children. The American College of Obstetrics and Gynecology, again, was interested. Anemia is a major problem during pregnancy and the postpartum period, so they were interested. And so AGHOG also had a working group. And again, they also decided to implement a race-specific threshold. Now, what we don't know, and this has been true for a lot of the work in these debates about race correction, is how widely were these recommendations implemented? There are over 6,000 hospitals in this country, each of which has a laboratory system, each of which has its own range of normal values. So if you were to ask me in 2000, after the AAP recommends race-specific thresholds for anemia diagnosis in children, what percentage of American hospitals reported their hematocrit and the normal values in a way that would allow pediatricians to do that? I think that answer is none.
Yeah.
I was an intern in pediatrics in 2001, 2002. I can't think of a single time when this question of race-specific diagnosis of anemia was ever mentioned, even though at that time it was officially the recommendation of the American Academy of Pediatrics to do that. So it's very hard to know what the relationship between these national recommendations and actual practice was. But the professional society had looked at the data and thought this was a good thing to do. But new data keeps emerging, and the membership of these working groups keeps changing. And so after recommending a race-specific threshold in 1998, the American Academy of Pediatrics reconsiders the issue in 2013 and recommends dropping the race-specific threshold. And that's interesting because that was 2010s was before the current controversies. So in that time frame, there were still many race-specific practices getting introduced. And against that background, the AAP decides to drop it. We weren't able to figure out the full details of what happened then. And then meanwhile, when the American College of Obstetrics and Gynecology recommends race-specific thresholds in 2008, they then reverse course in 2021. And so their decision to drop it, that happens in the midst of these national debates about race correction. So I suspect in that case, the obstetricians were influenced by the national debate. The pediatrics decision was made before the national debates. So there are many stories to get sorted out.
Yeah.
One of the things that's hard is people are now often pretty reluctant to talk about race and race policy. So if you call someone up and say, so tell me why your society made this decision that 20 years later looks a little bit racist, it's hard to get enthusiastic interview subjects to tell you what really happened.
Yeah. I was surprised being a pediatrician at seeing that history of the AAP and also realizing how recently, 2013 wasn't that long ago that they updated the recommendations. But I think similar to what you're saying, I can't remember this coming up during my clinical training or actually in practice. And so it's interesting how we hold on to some recommendations so tightly and others don't actually necessarily always translate.
And one of the things that's important to remember in this era, from the 1990s to the present, as you see professional societies and doctors having these debates, some people said, well, were all these people who recommended race-specific practices just racists? And that's not it at all. I mean, maybe they were, I don't know. But as far as I can tell, these were sincere, well-intentioned efforts by people who were aware of the issues. They were looking really hard at the data that they had, and they thought the judgments they were making were the correct judgments to make based on what they were trying to accomplish and based on the data that they had. And they were trying to help people. Most of the people who were pushing these race-specific tools were people who would have identified as race progressives, and that they were trying to do well by minority health. And they thought introducing these practices that provided special thresholds, special attention to these minority groups was actually the right thing to do.
Right. Yeah. And I think you keep coming back to kind of what what is the why driving all of these differences? Is it truly something genetic? Is it a prevalence of sickle cell disease in a certain community that's contributing to it? Or is it social determinants of health and access to nutrition and other things that contribute to anemia? I think that a lot of what we've been talking about so far has been focused in what was going on in America specifically. I'm curious, and you talked about it briefly in the article, kind of what the global response was and if what the WHO's take was on this specifically.
Many people who will say that all this attention to race in medicine is a specific problem of medicine in the United States. And when we published in 2020, the first article about race correction, the New England Journal of Medicine received a letter from a prominent physician in Sweden who said that we should have inserted United States in the subtitle because nowhere else in the world do they do such crazy things about race. And that's clearly not true at all. And sure enough, if you look at WHO records, they also have been considering this question. WHO is trying to cast a broad spotlight on health all around the world. And they see this problem in a huge way because they're surveying all of the world's populations and all of their physical diversity. And they're also very aware of diseases of poverty and malnutrition, which is far more prevalent on a global scale in the 70s, 80s, and in the 90s than it was in the United States. And so if you were a WHO scientist considering this problem, you would have been trying to decide, should there be one threshold for anemia across the full diversity of human populations and across an incredibly wide range of nutrition status? And so initially they do recommend group-specific standards, but then if you look at the specific groups that they name in their article, it's a pretty random group. Sometimes it looks like a racial category. Sometimes it's a national category. You can tell that whoever was writing this did not have a clearly articulated theory of what race was and is writing awkwardly about these different categories that they're trying to operationalize different standards to. But then the WHO has also reversed course. And the underlying problem for a lot of this is that basic question, what is race? And what should doctors do with it? And that has bedeviled American medicine and medicine elsewhere in the world literally for centuries.
Yeah, definitely. And I think coming back to so many pieces of that, from genetics to the social constructs surrounding it to who assigns your race. Is it the provider? Is it the patient? I think that, one of the other things that I've been reflecting on during our conversation was sometimes when folks think about race in medicine, and you touched on this a little bit earlier, the examples that come to mind are often things about misinformed practices or practices that resulted from, historically racist patterns, and then also things from outdated and incorrect assumptions about race. But this discussion on anemia feels a bit different than those examples that come to mind. And I'm wondering if you can talk a little bit about why that is.
It's interesting. If you look at some of the other practices, so if you would say, why were there, for nearly 200 years, race-specific standards for interpreting pulmonary function tests, and you trace your citations back, all roads lead to Thomas Jefferson and his notes on the state of Virginia, where he says that, and I don't know if he uses the term blacks or Africans, but he was talking about people he had enslaved on his plantation. They have a defective pulmonary apparatus because these African people are unwilling to exert themselves sufficiently as children to give their lungs the stimulus that lungs need to develop properly. Whereas if you enslave them and make them work hard, then you can ensure healthy pulmonary development. Now, I'm not saying that pulmonologists in 2024 who are using race-specific thresholds shared Thomas Jefferson's theory of lung development, but there is an intellectual lineage that goes back to that. Or for the kidney function tests, one of the early rationalizations was that African Americans are more muscular than other humans. And it's really hard to fathom what that reflects anything other than old ideas about plantation slavery and who was suited to do physical labor in the tropics. The anemia story doesn't have those kinds of echoes that we've been able to find, with one exception that lingers in the background, which is when in the US in the 1970s, whenever you report, this group of people, African Americans, had lower hemoglobin, the disease that looms in the background is sickle cell disease. And not sickle cell disease itself, the homozygous form in which people who have that do have really severe anemia and are well known because those people tend to have medical problems. But it's the carriers, people who carry sickle cell trait. And so it turns out there's some chunk of the U.S. population of African Americans, people who have ancestors who lived in malarial parts of sub-Saharan Africa, who are carriers of sickle cell trait. And some of them might go about their lives without ever noticing anything from having this carrier status. But if you measure them, it turns out they have a slightly lower hemoglobin level than people who are not sickle cell carriers. And so I think some of what would happen is when NEJM's data started reporting a lower hemoglobin level, I assume, I don't know, but I assume some percentage of doctors would have said, well, yes, that community has sickle cell trait. Of course, their hemoglobin is lower.
Right.
And so there might have been an expectation that fueled the sense that this was normal variation or normal for that population. I don't know that that's true, but I can easily imagine that happening. The way this figures into the debate later on is as the CDC and as the IOM are having their debates about how to interpret this lower hemoglobin level, I think people initially make the thought experiment. So again, this is going to be a crude oversimplification. But suppose you take 100 people, 100 African Americans off the street in Boston, and you measure their hematocrit, and 50 of them, the hematocrit is 40, and 50 of them, the hematocrit is 30. You'd say, well, the average hematocrit is 35. That's lower than normal. Would it make sense to then have one threshold for diagnosis of anemia in that population? If you did that, you'd be misdiagnosing both groups. You'd be overdiagnosing anemia in half the patients and underdiagnosing anemia in half the patients. And what you really need to do is recognize that what we consider these racial groups are actually heterogeneous mixtures of different subpopulations. And sometimes that's relevant. And so what happened is the CDC and the IOM were looking at their data. They would say, yes, there's a bell curve of distribution of hemoglobin in these two populations. And the bell curve in African Americans is shifted lower than the bell curve for white Americans. So the population average is lower. But if you look carefully, the African American distribution actually isn't a bell curve. It has two humps. There's a subset of the population that has low hemoglobin. And a lot of those people have sickle cell trait or other hemoglobinopathies. But most African Americans actually have a similar hemoglobin to white Americans, and they're the ones who don't have sickle cell trait. And so if you implemented a race-specific threshold for anemia diagnosis, you're essentially treating a heterogeneous African American population as if it was a distinct homogeneous population, and you're taking the majority of the population whose hemoglobin is like that of other humans and somehow saying, well, that's actually not normal for that group because your group normal has been influenced by the minority of people in that community. And so there's a lot of confusion about how you move between a trait that's a characteristic of a population, the average hemoglobin, and what that means for an actual individual patient in front of you. And so I think if you were able to get all the people who are sitting around the table at the CDC, what they would say is you don't want to have a race-specific threshold for anemia. But what you might want to know is what's everyone's sickle cell status, and then have a sickle cell trait-specific diagnosis for anemia. And people might say, then you'd have to test everyone for sickle cell trait. Well, many states do.
Yeah.
Massachusetts does. Every child born in this state gets their blood sent off, and you know everyone's carrier status. And so if you're a pediatrician and your patients and their families know their medical histories, if you see a 14-year-old and their anemia or their hemoglobin level seems a little bit low, you should know, is that person a carrier? And that will then guide your interpretation of that trait.
Right.
And so that is a call not for race-specific medicine, but for genotype-specific medicine, which is much, much easier to defend than some of these old race-based practices.
Yeah, and grounded in the physiology and the actual scientific rationale for why we're doing this. I think that, one of the things I took away was kind of the key questions that this debate seemed to bring out, which was, did these differences show an evidence of a race-specific difference? Was this evidence of a confounding factor like we've talked about? Or was this evidence of diversity within a group, which you had just reviewed? And so I think that the article really honed in on was anytime race is used in a risk calculator or in medicine, it's really important to pause and be thoughtful and ask for this why. I think that this has really highlighted the level of active debate that emerged from this, and that it produced a variety of outcomes that allowed physicians to and clinicians in general to kind of take whichever version of the answer they wanted. And so I'm wondering, knowing what we know now and being able to look back and reflect, what can this history of anemia teach us about the future?
In some ways, as you were describing it, it's a useful case study to remind everyone of some important points. So again, it's generally well known that the rates of sickle cell trait are much higher in African Americans than in other people in the United States. But I don't think anyone, no doctors would say, let's treat all Black people as if they have sickle cell trait. That would be, everyone would know that's a crazy thing to do.
Right.
Some people have it, some people don't. Don't generalize from the community to every individual. But in almost every area of medicine, that's exactly what doctors had been doing. And so to go back to the kidney function tests, those were initially justified by this claim that Blacks are more muscular than whites, which fell out of favor because it doesn't make any sense. But in the 2000s, 2010s, the most common justification was that there were certain alleles of an apolipoprotein seen in people of West African ancestry that are associated with kidney disease. And maybe that's what was driving the observed differences between creatinine levels and direct tests of glomerular function that you'd see in African Americans. And so they came up with this genetic rationale for using the race coefficient to calculate estimated glomerular filtration rate. And that was introduced in the early 2000s and became ubiquitous across healthcare in the United States. Well, now that you've heard the sickle cell story, the question you would ask is, well, hold on, what percent of African Americans actually hold that allele? And the estimates vary. It's somewhere between 15 and 30%, which isn't that much higher than the carrier rate for sickle cell trait. So the majority of African Americans are not carriers of this high-risk allele. And yet all African Americans were having their EGFR race corrected simply because of a trait that was seen in a minority of the community. And that doesn't sound very scientific or evidence-based. And yet that was the practice in every hospital across this country. And it's an opportunity for people to stop and ask, why is medicine doing this? Why is it that in the sickle cell case, people realized this didn't make sense? And in the EGFR case, it became standard practice. And I don't have a good answer for that question. And then once you start thinking along those lines and start thinking critically about some of these practices, and one thing I want to say, the article we wrote in 2020 didn't call for a rejection of race-based practices. It just called for careful consideration.
Yeah.
And if someone could show that this is actually an evidence-based scientific thing to do, then sure, great, keep it in. But our speculation was that if you looked closely at what was going on, you'd realize there were problems. And so back to EGFR. So one issue is it assumes that every member of the Black community had an allele that was seen in fewer than a third of them, which doesn't make sense. It also caused problems, and the best example of this is someone like Barack Obama, someone who's of mixed ancestry. Many people in this country are of mixed ancestry. I don't know, but I assume that all 6,000 hospitals in this country would have race-corrected Barack Obama's EGFR. He self-identifies as African American. A registration clerk at a hospital would have coded him as African American. He would have been race-corrected. That ignores the fact that, the language is crude, but he's only half Black. His mother was white. And so why is it that you assume his father governs his kidney function and not his mother?
Right.
That doesn't make a whole lot of sense. And that's, again, a case that echoes old practices of slavery, the one-drop rule, that if you have any Black ancestry in this country, you're considered Black. That was essentially what would be happening with Barack Obama. And then the second issue is, as we were told so often during his campaign for president, his father was from Kenya, which is not in West Africa. So it's in East Africa. And so Barack Obama, even through his Black father, is presumably at essentially zero risk of having this West African allele. And so anytime his EGFR would have been race corrected, which would have been routine practice at every hospital in this country, they were making a number of different mistakes. They were assuming that all Africans share a risk, even though there's enormous genetic diversity within Africa. They were assuming that he was all Black, even though one of his parents was white. And they were assuming that he was at high enough risk by being Black that they should assume that he has this allele, which exists in only a minority of the Black population. And so 3 very basic mistakes. And yet those mistakes would have been made routinely at every hospital in the country. And in many of these cases, that led to, arguably, to worse care. African Americans not getting referred to kidney specialists, not getting referred for transplants. And so not only was this scientifically not justified, but was providing bad care to a large community of patients. Back to the hematology case, was anyone harmed by having race-specific standards or not having race-specific standards? It'd be really hard to show. And I hope what would happen is that doctors would look at these results and the lab would flag it as high or low. And that would simply start a conversation that the doctor would have. Maybe doctors would then follow up with the mother and try to figure out what's going on in the diet. Is there a reason to believe that this is actually nutritional? And so I hope doctors were using these lab tests as a start of a conversation and not as a discrete judgment. But anyway, it's very hard to know how any of these guidelines were actually used.
Totally. One of the cases that comes to the top of my mind as you're talking is the use of race in the bilirubin toolkit, which now the recommendation has been taken away, but just thinking about being in the newborn nursery and seeing babies who are 24 hours old and needing to determine if a baby is Asian or not Asian and if they're at higher risk for developing jaundice. But really, what does that mean in terms of their liver function or the specific enzyme that was traced back to Far East Asia, and what countries does that include? We find ourselves uncovering a very similar conversation to the one you just outlined for EGFR. And I think that one of the questions that comes to my mind looking forward is, one, how do clinicians actually put these tools into practice? But 2, in the era of increasing artificial intelligence or algorithms or tools where people plug things into risk calculators without actually necessarily getting to see every line item in the risk calculator, what are the implications there, and how do you foresee this playing out in the future?
I think there had been a lot of hope early on. So more than 5 years ago, that the move towards these machine learning algorithms would solve a lot of these problems. The risk calculators of the sort we described in the 2020 article were mostly, for lack of a better word, what I'd call analog risk calculators. Doctors would be looking at the data themselves. They'd be doing linear regressions and multiple regressions to try to figure out which of the 10 variables under consideration were significantly correlated with the outcome. And then they would build those variables into their equations, and the equations were things that you could write down and look at. So you could see the coefficient for being African American is 1.3, and you could stop and think of that and decide if you were really comfortable doing that. And sometimes doctors were, sometimes they weren't. With the move to machine learning, now you can feed far more than 10 data columns into these analyses. You can have a data set that has 1,000 variables. And the analysis that the algorithm comes up with is often black boxed. It's just producing the output, and you don't know exactly the path it took to get there. And you can't figure out how race or not is being weighed. And early on, this summer after that article was published, I had a talk with the bioinformatics group at Stanford. And I said, well, can't you just remove race from the data set that you feed to the machine learning algorithm and solve the problem? And they said no, because the problem in the United States is that race co-varies with so many other variables. Race co-varies with zip code, race co-varies with educational attainment, race co-varies with income. So if you have any data set that has any kind of social determinant data, even if you erase the race column, they said race still exists like a ghost in the machine in the data set. And these algorithms can pick up those cross-linked variables and could actually be producing a race-informed output, even if race was not provided as an input variable. And since it's black boxed, you don't know exactly what it's doing. And so it's a very, very difficult problem. And it's an area of active research. There was research done at MIT and elsewhere that showed that AI algorithms could predict the race of a patient from a chest X-ray.
Wow.
And there have been other studies showing similar things with radiological imaging.
Mm-hmm.
And now there's this cottage industry of trying to figure out what on earth was this algorithm seen in these chest X-rays. Was it picking up on subtle differences in skin pigmentation that's not visible to the human eye, that somehow is visible in the raw data that's getting fed into the algorithm? Is it picking up on racially structured patterns of jewelry wearing or clothing? No one really knows. And this is a very active area of research. And the question is, how comfortable should doctors be using these tools that sometimes are exhibiting semi-magical powers that could be really valuable? We don't know exactly what they're doing. We do know that they're at risk of propagating various forms of bias that are in the training data sets. I think at least now people in the AI world are very aware of this.
Yeah.
And so algorithmic bias is a huge concern, not just in medicine, but in criminal justice and elsewhere. And so I have to hope that they're being very careful and that this scrutiny will lead to safe and reliable tools.
Yeah, definitely. Well, I think if today's discussion has reminded us of anything, it's that we have to understand where we've been to understand where we should go next. So I really want to thank you for your time today. And I think to close, one question that I wanted to ask is that what is one question about this research that you wish more people would ask?
The one question related to this, I could talk about other kinds of research, but related to this, the one question I'd really love to know, and I don't know how to answer this, is what % of medical decisions could be usefully informed by knowing someone's race or, more specifically, their genetic ancestry? And is that a big number or a small number? And if that's a big number, then medicine should be doing a lot of work to try to understand human variability and how it's relevant for medicine. But if it were a small number, and you could say most of the time we can actually just treat other people as if they were human, that would really simplify things. And there's some things like if you have a heart attack, it doesn't matter what kind of human you are. You want someone to put a coronary stent in your arteries within an hour of your heart attack. And if you're a hip fracture, you want to have your hip fixed. And if you have many forms of cancer, it doesn't really matter what kind of human you are. All that it matters is that you have this cancer and you want to get treated appropriately. Or for the common things, if you have an asthma flare, or if you have a headache, or if you have hypertension, I suspect most of the decisions that doctors are making in their day-to-day lives, it doesn't matter what kind of person that they're treating. All the attention for personalized medicine, I don't want to say it's barking up the wrong tree, but it may be a level of concern that's not actually needed in most situations. That said, there are certainly going to be some examples where it matters a whole lot. For people who do have sickle cell trait, or for people who actually have sickle cell disease, that level of human difference really does matter to their management. So I'm not a nihilist about human variation. I just think we need to be more deliberate in thinking, when does it matter? When does it not matter? And then how do you tell? And I'd love to figure out a way to answer that question.
Yeah, definitely. Well, I'm sure you've inspired a lot of readers with your writing, and it's brought up a lot of new questions, both on how we think about these things, but then how we actually apply them as well in the clinical setting, ultimately to, reinforce one of the tenets that we all take on as clinicians, which is to do no harm.
And the last thing, often these things about race-specific practices, they get taken for granted so quickly. And so one thing I do want to do is give a shout out to the students and trainees who have really been the brains behind a lot of this questioning over the past 10 years, because they're the ones who come in and give medicine and medical practices a fresh look and are asking these questions, well, why are you doing that? And in many cases, the attendings or their professors had a hard time answering that question. And that's led to some really productive research.
Totally. Yeah, I completely agree. Having those learners in the room really is the conscience of medicine and reminding us why we do the things the way we do them. So thank you again so much for your time and being our very first guest on NEJM In Studio. We hope to continue to learn from you and all the research that you have to come. Thank you again to our guest, Dr. Jones. His full article can be found on nejm.org. Join us next time for NEJM In Studio. Thank you. Funding for this interview is provided by the Doris Duke Foundation, committed to building a creative, equitable, and sustainable future.